Go ahead and call the SURG Prevention Subcommittee meeting to order. Thank you all for being here. I am going to turn this over to Ms. Rodriguez to establish a quorum through our roll call.
Thank you. Okay, Senator Fabian Doniate.
Present.
Chair Jessica Johnson.
Present.
Debbie Nadler.
Present.
Angela Nichols. Vice Chair Eric Schoen.
I'm here. Good afternoon, everybody.
And Senator Heidi Sievers-Gansert.
Here, thank you.
Thank you. Chair Johnson, we do have a quorum.
Fantastic. Thank you so much. I do see Angela Nichols logged in, but maybe not with current audio. If you can keep an eye on that, that'd be helpful and advise the group. Thank you everyone for joining today. I really appreciate you all being here and taking time for our meeting. With that, we'll move on to agenda item number 2, which is our period of public comment. Again, I'll turn it over to Ms. Rodriguez so I can ensure we're in compliance with NRS. Ms. Rodriguez?
Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241020. If you are dialing in from a telephone, please dial 1-253-205-0468. And when prompted, enter the meeting ID, which is 825-0031. 7472, and please press 9 so the host can prompt you to unmute.
Thank you so much. And with that, Ms. Rodriguez, do we have anyone for public comment?
Chair Johnson, I do not see anybody at this time indicating that they would like to provide public comment.
All right, wonderful. We'll hold for just one more minute here in case anyone is slow to raise their hands or come off of mute. Wonderful. With that, let's go ahead and move on to agenda item number 3, which is review and approve our August 29th Prevention Subcommittee minutes. I'm hopeful that my colleagues on the phone here have had a chance to review, and once you're ready, I might entertain a motion to approve the August 29th minutes.
Debbie Nadler, for the record, approve the minutes for the August 29th.
Awesome. I have a motion from Ms. Nadler. Do I have a second?
I would second. Eric Schoen for the record.
Wonderful. A second from Mr. Schoen. All in favor say aye.
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 This is Heidi Gansert. I'll abstain because I didn't attend the meeting. Thank you.
Thank you, Senator Gansert. Any other abstentions? All right. Motion carries. Our minutes have been approved. I always get those parts backwards. My apologies, everyone. Thank you for folks who hopped in. With that, I will move to agenda item number 4, where we will receive a presentation on prevention funding from Abe Meza and Tracy Palmer. Before I turn it over to our presenters, I wanted to thank you for making time for us today and remind my subcommittee members that this presentation was requested for our recommendation number 1 from the prevention subcommittee that's currently in draft form, that we're looking for additional information for revision or finalization. That recommendation is to recommend to DHHS or whichever entity oversees the primary prevention dollars to double the amount of investment in primary prevention programming every year for 2 years for ages 0 to 24. So I'm asking my surge prevention colleagues to take notes during this presentation of any items that would help our committee with additional guidance around that recommendation. And to our presenters, we have about 10 minutes with 5 minutes for questions. So I'm hopeful if you have more information than that, that you could prioritize anything you've prepared that pertains to this particular recommendation. Ms. Rodriguez will give a 5-minute warning and then a 2-minute warning as we approach that 10-minute mark. With that, I will turn it over to Tracy Palmer and Abraham Meza. Thank you for being here.
So good afternoon, and thank you for having us here. This is our first round of being asked to present here. I'm actually hoping it won't be our first it'll be the first of many, actually. So my name is Tracy Palmer. I'm a health program manager. I'm the substance use prevention, treatment, and recovery section manager for those areas. I also oversee prevention general fund dollars, and I also oversee the Partnership for Success prevention funds. So today, I also want to introduce Abraham Meza. Abraham is our SURG liaison, and he is also one of my new health program specialists in the treatment field. Also on the call today to support us, along with talking about prevention, is Jenny Bear. Jenny is the prevention lead specialist here within the Bureau. So with that being said, we do have several slides and a lot of rich information. We were asked to kind of present on kind of a quick overview of the Bureau's funding, and then an overview of our substance use prevention, treatment, and recovery area. And then also we were breaking it down into just the prevention piece of it. So you can see that when it comes to reporting. And then also how do we extract that information, what system that we use for the prevention piece of it. And as to the point of if there is more or additional information down the line, or if we don't get to finish today, I'd be more than happy that we can come back and answer questions and do so. So on the next slide, and not knowing who has the PowerPoint or not, because we unfortunately did not get that to Emma or Jessica in a timely fashion where where they could post this and get it out, but we'll walk through this. So as I had mentioned, I already kind of went over what the agenda today and what we hope to be able to present to you. So in the next slide, that just kind of provides a chart, a quick overview of our overall funding. This just gives you a brief synopsis. The BHSP, our Behavioral Health Services Plan area, that's the dark blue. The Substance Use Prevention and Treatment and Recovery, that even though it looks a little orangish, or yellow, it is the orange side of the house where it has the 24,325,177. We will be diving deeper into that particular piece of it. To save time, I'm just letting you know the other areas of this pie includes OSP, Office Suicide Prevention, the CRS, that is your Crisis Response Services, and then PG, which is our problem gambling. So on to the next slide. And so this is just giving you a brief overview of our Bureau and showing the state general fund dollars, which include our alcohol state funds, the methamphetamine state funds, marijuana state funds. And then we wanted to kind of give you a quick snapshot of a few of our revenue funds, which is liquor tax, also known as the alcohol tax funds. And then we actually have certification revenue funds. In our federal dollars in the Bureau, we deal with the substance use block grant. That is approximately a $20 million block grant. The Partnership for Success, acronym PFS. And then Women's Services Postpartum, which is a new federal grant that we have. We also just wanted to share with you when any state who accepts and provides substance use block grant dollars, we have what we call a maintenance of effort. And so we're required to demonstrate that as a state, and we use our general fund dollars to utilize the support of block grant activities. And so a lot of people call it a match, but SAMHSA calls it a maintenance of effort. So into the next slide. And then the next slide, I'm just kind of showing you, and you'll be able to see, and all of these PowerPoint, or this PowerPoint will be shared and given to Jessica and Emma to be shared. But to that point, each one has a particular funding category. This is how we try and keep things straight here in the Bureau. And when we look at funding sources, this is what we look at. So treatment, we just wanted to share a little bit of some of the other sources. Like I said, we're not just a prevention, we're the substance use prevention, treatment, and recovery. So we're just giving you a quick snapshot of some of the other funds that we are handling here in the Bureau. This one is the treatment. Treatment is that alcohol focus, and it's approximately a $2.4 million funding source that we have. And we focus in our criminal justice area. We focus on recovery friendly. And we also use these funds to support our peer recovery support services, transitional housing, and Nevada Care Warm Line. Next slide.
We have just about 5 minutes left.
Okay. I really won't be able to hit a lot of these. Okay, so with that being said, I would like to go to, I'm going to take you down, and again, everybody will be able to walk through the whole idea of these slides. I'm going to take you to, go to slide 18. All right, so then the next one. All right, so we're talking about prevention. This slide will tell you a little bit of the breakout. When we talk about in our annual report that we have to do, these are the dollar amounts that we look at for our substance use primary prevention. In our block grant, we provide about $3.9 million that goes out to our community members. And then we also wanted to reflect and show you, and that's why it's highlighted in the yellow, the funds that we focus on, including the COVID and the ARPA is in there. And then we also have some other funds that come in and that focuses and supports in our primary prevention services in the state of Nevada. And then in prevention, if the next slide, and this again, as you can tell, these are starting to, one trickles down to the next one and opens it up. And it's like, Shannon Bennett, our bureau chief, has mentioned many times about it being an onion. And that's exactly how this particular overall presentation should walk you through the different areas of how we break it down. So this particular slide shares with you our primary prevention expenditures. I probably could spend the next 5 minutes just sitting here looking at this one for you all. But there are SAMHSA has 6 strategies. These are the prevention strategies: the information dissemination, education, alternatives, problem identification, referral, community-based processes, and environmental. Another little footnote that we put down at the bottom is the 2023 Substance Use Block Grant Annual Report. It's Table 5A. I wanted to make sure that I put that down there because any citizen has the ability to go in and look at this report. So this particular, this slide and many other slides that I've provided, you as a citizen or anyone has the ability to go in and look at the different strategy areas that we have focused on. And you can see that we've done 42% of information dissemination. So that, and then there's that community-based referral at 27%. Our prevention coalitions have done an excellent job of working with the communities, getting the information out into the communities, working with our education leaders, and identifying some other alternatives. It may say 1%, but 1% can be a much higher dollar amount. And as COVID has happened, we have been able to see a lot of adjustments, and people have really done an excellent job of working within the means of what they have, and then working through the pandemic, and then also seeing how they're able to enhance and expand themselves, and working with the different community and stakeholders. So with that, I'm trying to think of what's the next best area. So let's go to slide 24 and go to where we talked about data.
We have about 2 minutes left.
That's why I wanted to jump to that one. Okay. Thank you. It's all good. And so let's go to the next 2 slides. So perfect. So this is our WIT system. So the prevention entities are expected to enter their activities in alignment with the cost and to the WIT infrastructure for treatment services, what it's called, and it's a WIT system. SAMHSA requires all states to have a data tracking system. And several years ago, Nevada decided to go with the WITS. So the WITS is great in the aspect that it helps us track. It can help us track age. It can help us track it from an individual base, from a programmatic base. Here, this is just a great example of we can immediately see individual-based programs that are implemented through our primary prevention entities that an age range from 25 to 44. We're having to really look at those dollars that we're spending towards that age range because we know it's a problematic age. We know that they're struggling, and the more that we can reach out to them and provide prevention services, the better. On the next slide, you'll be able to see it from a program perspective in a larger view. And you can see how this is an example of age not known. You see 9 million. So in the prior years, we've had a lot of age not known. We weren't able to track the age as well from a programmatic and from a larger spectrum. And if I would have had more time, I would have definitely taken you to the next particular slides that actually show how the coalitions have been able to really enhance what they were doing. Go to one more slide. And they've been able to really look at the age not known, and they've been able to find a way to integrate, the age of the person that they're working with. So this slide shows a perfect example of what they've been able to accomplish and what they've been able to help report to the state, which then in turn, I've been able, and my team have been able to report to SAMHSA, which they've been extremely pleased to see that, as you can tell, it went from 9 million of unknown to now we're down to 219. That's a huge, huge accomplishment. And so with that, the primary prevention pieces, we also work on evidence-based practices. And the WIT system is able to, if you go to slide 36, able to really help show us where we have some evidence-based practice programs and the dollar amounts, the type of evidence-based practice programs, if it's direct, indirect, whether it's selective or unspecified. Those are the particular categories, as we call it, from the Institute of Medicine, and it's a classification of prevention. And so we just did a little blurb down below for defining it for you. So with that being said, we're able to really see these evidence-based practice programs that the coalitions have been able to put into place, and we're able to work with them, whether it's a provisional program or whether it's a evidence-based program to fidelity. With that being said, if you go to slide 38, thank you so much for allowing us to talk. And I hope I got through 38 slides within 10 minutes. So so we'll take any questions and comments and happy to address. And yes, ma'am, Debbie Nadler.
Hi there. Thank you so much for that great presentation. I do have a couple questions. So as far as the evidence-based programs that you're referring to, and I'm sorry for asking this, but I've looked online, I've looked everywhere, and I don't see the actual programs for middle school, high school, college. What I'm seeing a lot of is programs in Reno and not in Las Vegas. And I know you're saying we have a certain dollar amount or certain target that we're looking at, but as far as 11, 12, 13, 14-year-olds, and I also wondered the date, you know, that you're looking back at these numbers, because obviously we all know our teens that are using starting at age 11 really, but some 10 has increased 40-60% over the past couple of years. And I see things that they're doing in Reno, the QR codes on the back of the student ID cards for mental health, different kinds of services, and they're not doing it at schools, or they're not mandating it in schools here in Clark County. So I'm just confused on the programs that are being done because I don't see them. Is there a list? Can you give us a list of all the programs, I guess I'm asking, which are being implemented in Clark County, in Reno? Because Reno is using DARE, which has revamped their program. I've talked to the director several times, and for some reason we can't get him in Clark County. So I just feel like it's not appropriated correctly.
Thank you, Debbie, and awesome question and comments. And I just want to say thank you for that feedback, because your age range that you're speaking to is right on target. Those are some of the age range that we are seeing, and that the coalitions, prevention coalitions, have been also targeting on. And there is like an overall large list that you could find from SAMHSA and so forth. But what I'm hearing from you is you would like to at least know the list of the evidence-based practice programs that are happening in schools in Clark County, because it sounds like you have the ones in Reno. And so
Yes.
to that, I know that I most certainly can ask the coalitions who are in Clark County. We have CARE Coalition, and then we have PAC Coalition. And then I believe that we have, I think I saw Jamie Ross, who's a PAC Coalition director, on today. And she might be able to give you a name of a few that she already knows that are in place. They've worked really hard to talk with the schools and integrate with them. They do before and after school programs, and then they do some educational type programs within the schools. They do have to work very closely with the teachers, and you are correct, they do have to work very closely and get permission from their school administrators, and that's a lot of work, so they do that. But most certainly the date range that they work in, they start heavily, you know, probably in the middle of the summer, trying to implement and getting these programs ready. And then they go from they have from October until like a September year where they can really start working with the schools and implementing. Sometimes because the schools will only allow them a certain amount of time in the school districts. So that's why you may only see a 6-week window or a 3-week window. And so that's very difficult. They do and continue to do that. With that being said, more than happy to provide the SURG representative, either Jessica or Emma. You want that particular list, we can get that for you.
Thank you, Tracy. And I did see Jamie give a thumbs up, so it looks like the PAC team will be ready to provide that.
Awesome.
Other questions from the subcommittee? I have a couple on my list, but wanted to hear from my colleagues. As well.
Chair, go ahead. I have a question, but you may have it covered as well. So I will wait.
Okay, wonderful. Thank you, Mr. Schoen. Tracy, thank you so much for your presentation and the abridged version on the fly today. We appreciate that. I'm curious, does CDC or SAMHSA or another funded entity have like a ceiling or a floor recommendation for primary prevention funding, like a dollar amount or a per capita funding amount that exists? And if so, can you speak to where Nevada's at in meeting that?
Yes, so on slide 10, actually it will kind of show you where we have dollar amounts for the substance use block grant. And to that point, we are required, all states are required to have a minimum of 20% out of the dollar amount that you're awarded. So with that being said, the 20,537,145, that has a minimum of 20% set aside. And and that's an approximate 4,107,429. And that is primary prevention minimum.
Thank you.
So what we try and do is we try and hit, like our goal was at 23%. This year, we've tried to hit a 25%. We currently are about at a 19%. So I've been pushing the coalitions, and they've been doing their due diligence of not only getting the dollar spent, but making sure that we've account for it appropriately. I'm certain that we'll meet it. But again, that's why we do project at a higher percentage above that minimum of 20%.
Thank you. I know that you're referring to the block grant here. What about
Yes, ma'am.
other funding that's not included in the block grant?
So other funding not included in the block grant. For example, are you talking about like general fund dollars?
Or other sources of primary prevention dollars?
So
Thanks.
okay, so other primary prevention dollars, for example, when I talked about on slide 15, probably didn't talk about that one. But that one is a Partnership for Success grant. That is all 100% for primary prevention. So all of those dollars are associated to, and that is discretionary grant from SAMHSA. This year, the year prior was 2.1 million. This year is 50% of that we got cut. So we only have about 1.6% or 1.6 million, sorry.
Sorry, thank you. And so does that factor in? I know that the block grant has the 20% requirement. I guess I'm asking, is there like a recommended per pupil dollar amount funding for primary prevention programming in schools, or what does the reach look like into youth activities with the dollars that you have at your disposal now?
So if I'm understanding your question, you're wondering, is there an actual percentage across the board? There is not a requirement or percentage across the board. There is certain standards or certain assessments that are done where we must submit our information to SAMHSA. They compare us against other states, and then of course that becomes that national standards. And when it comes to other percentages outside of just what a terms and conditions of a funding indicates, then no, I would not have that answer right now. And I'm not too sure if there's a set answer to that. So I would have to actually try and research that. I'd be more than happy to.
Okay, thank you. And I just had one more question, and then Mr. Schoen, if I didn't ask your question yet. So with the dollars, the primary prevention dollars that you have right now, what would you say is your reach for all students in the state. I know that's a big ask, but I think that's sort of our recommendation for this funding is really looking at that reach or that, penetration into the primary prevention programming, and curious to know if you have an idea of what that looks like across the state.
So I just want to make sure that for clarification, because I'm not sure I'm understanding your question. When you talk about the reach, are we talking about reaching each school and providing prevention services in each school with each student across the state of Nevada?
Yes.
So that's why we have 10 prevention coalitions right now that are heavily in the different counties. And so they are reaching as far as they can. So even in the rural areas, so we have all counties are being addressed, and they are going into each school area. And to the point earlier, not every single school is going to have open arms. And so the coalitions are working really hard with those. Some rural areas are a little bit harder to reach. And so this particular funding, when we talk about the dollar amounts for CAT 28, which is our largest when it comes to prevention, then that set aside and working with additional dollars that the folks have asked for, we're hoping that that's going to give them additional funding to reach out to the schools that they haven't been, or the youth that they haven't been able to do, because we know that not all of them are going to be okay being reached in the schools. That is completely up to that district. But there's also the Boys and Girl Clubs or before and after school programs. The goal is we are statewide. The question comes down to, I think, is it the amount of funding, or is it the amount of county administrators in the schools that are allowing them in and allowing enough time away from the academics? That is a part that we do work with and struggle with. And again, I'm not too sure if I'm fully answering your question, but when it comes to a saturation plan of getting prevention in every single area of Nevada, I believe they are out there already. The question is to the extent of really still working with their stakeholders, the community partners, because we still have some rural areas that are a little bit more reserved and don't want as much people and outsiders in.
Yeah, wonderful. Thank you for that. And we've had some coalition executive directors present on previous calls too. So very excited about their work, and just I think we're really trying to think about sort of what additional support for this this mechanism that your team and others have built, how we think about that.
Thank you. And then to your point, I just want to say in the rural areas, they've done a lot of work also with the tribal communities. And that is also part of that reach, right? It's part of expanding out and making sure, including the military or the LGBTQ communities. And so there's a lot of work that they are doing, a lot of work that we're still doing and enhancing. So thank you.
Yeah, Mr. Schoen and then Ms. Nadler.
Yeah, thank you so much. Thank you, Ms. Palmer, for your presentation. I just have one question. As you were going through your presentation, I was trying to add up all the different various monies going to prevention, and I couldn't come up with a grand total for what we're spending on primary prevention. Could you do that for me? Could you just give me a round number for, is it 10 million? Is it 15 million? Can you give me an idea of how much total is going to primary prevention?
So right this second, I probably couldn't, only because I'd like to give everything its due diligence and make sure. And to your point, Eric, I definitely could come around and pull out that number for you, a lot closer than just doing an estimate. But yeah, I'd be more than happy to do that.
That would be really helpful. Because I have 3 or 4 different amounts and I don't know how much they overlap with each other. One of the things we're trying to figure out as a committee is the gross amount, essentially. I mean, in addition to all the other questions that have been asked, the gross amount of funding already going to primary prevention so that we could set a reasonable goal for trying to get that amount increased year over year.
Perfect. Yeah, I'll be more than happy to take a closer look and get that number for you. And to that point, we have been able to do in the fiscal year 22, 23, and then of course going into 24, we've done prevention efforts with the COVID and ARPA, which are supplemental dollars. Do you want that also part of it, even knowing the COVID dollars end, right? And the ARPA, the American Rescue Plan dollars, for the most part, will be ending in 24, 25.
That's a great question. I'm glad you asked. I would like to know basically the state's commitment. And then I would, those other sources that you listed as well, that'd be helpful to know as an adjunct. But I'd like to know, coming from the state of Nevada, here's how much we're committing from our general fund towards prevention efforts.
And okay. And you're looking in current year right now for 23 and then 24.
If you have it, yes.
Okay.
This is Heidi Gansard. Can I add to that? You know what I think is important is to break it out. So Eric, you asked for state, but I think if you put a spreadsheet together, it would be state, it would be federal match, and then you would probably have like the COVID ARPA money. That was one time. That would give us sort of a complete look of, across, so that we know what the total spend is. And then also, like the COVID ARPA type dollars that are not going to continue. And when you put those together, maybe you can put the expiration on that, because I know there's a certain amount and they're going to drop off at 12/30, 24, 25. I'm not sure when, 12/31. Thank you.
Yes, no problem, Senator.
Thank you, Ms. Palmer. I think we have time for one more question. Ms. Nadler?
Thank you very much. So I don't know if anybody's aware of this or not, but in September 1st, 4 states mandated opioid prevention curriculum. And they've mandated it in Oregon, Illinois, Texas, and Mississippi, and it's getting ready to pass in California. Perhaps is this something somebody in legislator or somehow we can get this required lessons on the dangers of opioids and all the new deadly synthetic pills coming in, because they've now mandated it. So I don't know, is this something for legislator to do?
Thanks for your question, Debbie. Tracy, if it's all right, I'm gonna just hop in and respond to that, if that's all right with you. I know we've talked often on this call about focusing on either different topics or other areas, and have from my brief summary of those discussions have sort of come around to know that we'd want to adhere to best practices in primary prevention, but lean into sort of what the local conditions, as Ms. Palmer alluded to in her earlier response, sort of hold in terms of how to best allocate those topics or discussions or everything else, really leaning into those 6 strategies of primary prevention and knowing their evidence base. So that, from my perspective, Debbie, may be a separate recommendation that our committee could consider at a different date, but wanting to just ensure that we had some data going forward for this particular recommendation.
Thank you, Jessica.
Sure. Any additional questions from the committee for Ms. Palmer? All right, wonderful. Thank you so much, Tracy and Abe, for your preparation of this presentation today. It sounds like we do have a couple of items for follow-up, and I know Ms. Rodriguez will be happy to take those in advance of our next meeting. And I also appreciate your offer to return for a presentation at a later date if needed. So thank you for that. And all the work that went into getting this out for us today.
Thank you. And again, appreciate the opportunity to talk with everyone and present And I'll definitely get connect with Ms. Rodriguez and make sure we get you some of those answers. Thank you.
Terrific. Thank you so much.
Mhm.
With that, let's move to agenda item number 5, which are the Prevention Subcommittee recommendations, review, and discussion. I'm going to call the committee's attention to page 1 of our surge prevention and harm reduction recommendations from September handout that was posted with these slides that will provide any additional supplemental areas for what we're discussing today. Ms. Rodriguez, did you have any additional details to orient the committee as we review these in advance of the October large surge meeting?
Emma Rodriguez for the record. Yeah, I would just add that I think it's helpful to download that handout off of the SURG website, because that is really, we couldn't fit all that information on the slides, and that has the most comprehensive information for what we've seen, and we do have the page numbers listed on the slides as we go through them.
Thank you. Wonderful. So let's, with that, let's move to recommendation 1, since we just heard the presentation from DPBH from Ms. Palmer and her team. I'm open to hearing from the subcommittee members if there's additional workshopping that needs to happen to this recommendation as currently written. And then any opportunity or volunteers to complete the additional qualitative information. So do the subcommittee members have any additional wording or guidance recommendations for prevention recommendation number 1 at this time? Ms. Nadler?
Yes, hi there. So under that one where it says every 2 years for ages 0 through 24, is there something we could do with that wording? Because we don't know next year if we're going to have another fentanyl-like substance, which we're already seeing, nitazene, that's going to completely be all in the class. Does it have to be every 2 years? Do we have to specify every 2 years on this? Is there? I just think it needs to be a yearly thing. That's just my opinion.
So your proposal is for an annual consideration, or to double the amount of investment in primary prevention programming every year for ages 0 to 24?
Yes. Because of the ever-changing dynamics of this epidemic. And who knows, God forbid, we might have 8-year-olds using. I mean, it's dropped from 15 to 14 to 12 to 11. So I guess due to different circumstances, at least review every year. Not necessarily invest, but review.
Thank you. Mr. Schoen, I see you also came off mute. Would you like to speak as well?
Sure. Yeah. The reason the recommendation reflects 2 years was to mirror the how often the legislature meets and makes those funding determinations along with the governor's budget. So that's why we had every 2 years down there. I mean, if there's an annual part we want to add, I'm open to hearing that, but that's why we did that. My other thought is that without having a better idea of the amount of funding being spent, and I hope we can get that in the next couple of weeks, I feel a little bit premature making a final decision on this recommendation today.
Thank you for that. So what I'm hearing you say is to keep the investment component at every 2 years in alignment with the legislature, but if there was an off year sort of review, that would be an additional area that we would need to add language on. Ms. Nadler, did you have a comment on that?
No, I was going to say that too, to have the discussion on off years, since sometimes we meet 3 or 4 times throughout the year to decide, it takes us a while too to come up with ideas. So I think off year discussion would be good. Proactive, Yeah.
So to double the investment in primary prevention every 2 years and review the funding annually. Mr. Schoen, you're much more the wordsmith than I am. I don't know. And review the funding allocations annually.
Sure, if inspiration strikes, I will let you know.
All right. Did the committee have additional recommendations did we want to change DHHS and then after the / to DPBH? In the first part of this recommendation, since we have whoever oversees the dollars, because we weren't entirely sure.
Good
Is that
catch.
more clear?
So, yeah.
Yes, I agree.
So recommend to
Debbie
DHHS / DPBH. Maybe there's a more expert person on the line with the state acronyms who could help correct this language. All right.
Hi, this is Tracy Palmer again. I don't know if you
Thank goodness you're still here. Go ahead, Ms.
I don't know if
Palmer.
you need my assistance or not. What exactly you recommend to DHHS / Division of Public and Behavioral Health? Is that the goal that you want to send it to our area of the bureau within the DBPH?
Correct. Would it be more appropriate for us to say DPBH here or DHHS or another entity?
So if you are addressing it to not like maternal health or to another sector within the DBPH, if you want to send it to the Bureau of Behavioral Health, Wellness, and Prevention, then you kind of do like a dash, or there you go. Bureau of Behavioral Health, Wellness, and Prevention.
Okay.
There you go. Yeah.
Thank you for helping us with the wordsmith.
No problem. Thank you.
So should I delete the DHHS part or keep it?
This is Tracy again. I think it's appropriate to keep it because it shows the overarching.
Terrific.
Chair
Thank you.
Johnson, this is Elise Monroy, an ACRN member. I'll just remind you that the Fund for Resilient Nevada lives in the director's office, which is part of DHHS. So I think it's appropriate to leave that. I'm so sorry for butting in. I just didn't want to see it get deleted. Thanks.
Thank you to the attendees who spoke up today to help us ensure that we could take out whomever oversees dollars as a parentheses and make a few edits to this particular recommendation today. So thank you, and thank you, Emma, for helping us edit on the fly. It does sound like for today, we are just waiting, as Eric mentioned, on that larger grand total so that we could amend this perhaps at a future meeting with an actual dollar amount or determine any other amendments to this recommendation. I do believe that we'll need the additional fields to be completed at this time from the SEI team, unless other members of this committee are jumping at the chance to complete this in the form. I'm happy to volunteer to complete the qualitative and other elements associated with this recommendation to have the justification summarized in advance of our October meeting, but I'll pause in case others on the committee would like to take on the extra work for that. All right, hearing and seeing none, I'm happy to take my best effort to ensure that we have that information in advance of the SURG meeting in October. Thank you. All right, Moving on to prevention recommendation number 2. This is around specifically the tobacco and control funding prevention. Emma, did you want to walk us through any additional fields that needed to be completed for this recommendation number 2?
Sure. So I believe from the survey, we had all of, what you saw on this slide, that was already completed. And in the August subcommittee meeting, you all had a discussion of those qualitative elements. So we summarized that on this slide. It's also, I think it's in the handout. So I think we're just trying to get an okay on whether this looks good, if there's anything subcommittee members want to change. And I think we've already approved the recommendation language, but it's still an opportunity for the subcommittee if they do want to change any of that before it moves to the full surge for the October meeting.
Great, thank you. Ms. Nadler, I see your hand up.
Yes, hi, Debbie Nadler for the record. If I'm not mistaken, I believe we had spoke about this before, and somebody who did the presentation was going to get us the numbers of the kids using marijuana comparatively to the kids using tobacco. Because, and I could totally be looking wrong, but everything I'm looking up in our state, we have more kids using marijuana than tobacco. And marijuana is more a kickoff drug than tobacco. I thought, weren't we going to get some kind of information related to the numbers with marijuana, if I'm not mistaken? Because I think marijuana should be added to this.
Yeah, thank you, Ms. Nadler, for your comment. Ms. Rodriguez has been working diligently offline to schedule a presentation on that particular topic. Unfortunately, the subject matter experts' availability didn't coincide with any of our scheduled meetings. So I know that she's still working to schedule that meeting with Mr. Allo. In the interim, even though it's called tobacco control and prevention funding, they do work, as Mr. Allo mentioned, around vaping and other mechanisms. So this is just the sort of the name of the allocation for some of these dollars as it exists, is my understanding that it targets a variety of efforts, including sort of broad vaping prevention efforts, which is what he was specifically speaking on. Mr. Schoen and then Ms. Nadler, I'll take your follow-up comment.
Yeah, thank you, Chair. I just realized something, and I don't know that we've stated this clearly, but I don't want this recommendation to come at the expense of prevention funding already allocated elsewhere. In my mind, this is a value-added recommendation that would not rob from the already designated prevention dollars. So this is above and beyond.
Thank you. Is that a statement, qualifying statement you'd like to add to the end of this particular?
Yeah, I think that we should say something along the lines of the intent of this recommendation is for this to be value added. I mean, whatever the right verbiage would be, that would delineate that. But it should not be at the expense of current prevention programming.
Thank you.
Yep.
Ms. Nadler?
Eric, thank you for stating that. I 100% agree with you. And I know words are words, but is there anywhere we can put tobacco / vaping / marijuana? I just don't want it to be left out when we're looking at that. Can we add the word marijuana, vape? I mean, where that bottom bullet point under urgency.
Sure. So what I'm hearing you say, Debbie, is you'd like to add a bullet point under urgency around that this includes tobacco, cannabis or marijuana, and mechanisms such as vaping.
Yes, perfect. If we can do that, thank you.
Tobacco and other mechanisms such as vaping. Emma. Thank you. Other suggestions or recommendations on the qualitative elements or any amendments to the prevention recommendation? I did have one language recommendation in the I don't know if you want to add it here on this slide, Emma, or before. We do say the master settlement agreement. Can we just include the word tobacco master settlement agreement? I am aware that there's been just some offline confusion perhaps about that, and if folks are newer to the field, just making sure that we're intentional about that language. Thank you. There any additional information that folks would like to add at this time? Debbie, did you still have your hand up?
No, I'm sorry.
Okay. No worries. I didn't want to intentionally ignore any hands that were up or miss it. Any other recommendations before we move to number 3? Or language changes? All right. Hearing none, we'll move to recommendation number 3, which is on page 6 of the handout. Because we workshopped this recommendation in one of our committee meetings, we still need some of the additional research links and fields to be completed for the cross-cutting elements. And I don't think, and the qualitative elements to be presented at the October meeting with regard to this particular recommendation around alcohol outlet density. I'm happy to take the time to discuss this today, but I know we have a few other recommendations to review. As an alternative, I'm happy to volunteer and add it to my list to come up with the qualitative elements associated with this, unless there are other committee members who are interested in some committee homework to complete these sections.
Chair Johnson, Emma Rodriguez for the record. I wanted to note there was some discussion on the qualitative elements at the August subcommittee meeting. So that's presented here. So perhaps you could take a look at that, see if there's anything else you want to change, and then submit any research or links and that other information.
Just complete the missing fields.
Yes.
Okay. I'd be happy to do that unless someone on the committee objects or is burning to complete it themselves. All right, hearing none, I'll get the information over to the SEI team in advance of our October meeting for the search. All right, wonderful. Thank you for preparing this as well, Emma. And I'll add to these qualitative elements that were discussed at the previous meeting. Many of you also followed up about the additional prevention recommendations from our previous report that were resubmitted. So we do have a few of those in here as well. We discussed adding what is now prevention recommendation number 4 around Medicaid billing. We discussed this to be resubmitted from the 2022 report. However, we didn't get any additional survey information on this item. So I'm looking for any committee volunteers who would like to submit the qualitative elements, the impact, capacity, feasibility of implementation, urgency, and recommendation, or if we'd move to strike this from our 2023 recommendation report. Input from the committee on this. Would you like to keep this on our 2022 recommendation report going forward?
Yeah, Chair Johnson, Eric Schoen for the record. I do feel like that's an important recommendation in terms of evolving sustainability for our prevention funding and having it recognized in a similar vein that we do as treatment in terms of the value of these services. I don't have the bandwidth to do this myself in terms of taking that further, so I can't help you there, but I do think it's an important priority.
All right. Thank you, Mr. Schoen. Thoughts from the other subcommittee members? All right, hearing none. So it sounds like we can leave this on the report, Emma, and unless we're able to identify an additional volunteer, or if we want to discuss now the impact, capacity, feasibility, then it may just be blank for those particular qualitative elements as it moves to the larger subcommittee. So I'll pause for a moment in case folks want to speak to the impact, capacity, and feasibility of implementation, urgency, or advancing racial and health equity.
So Chair Johnson, Eric Schoen for the record again. I think this is really important. I don't think we should feel bad about not being able to do it all. I mean, we're simply, a small group doing what we can. So my recommendation is we continue through the list. And if we have time at the end, maybe we can come back to this and try to do some more work on it.
I welcome that idea. Thank you, Mr. Schoen, for the recommendation. Ms. Rodriguez will keep me honest to come back if we have extra time. With that, we'll move to our new prevention recommendation number 5, which is one of our previous ones around harm reduction. This was resubmitted based on the discussion from our August meeting, and the qualitative elements were also submitted and included on page 10 of the handout report. I'll just pause in case there are any additional changes to this recommendation. All right. I'm hearing none. Happy to move to recommendation number 6. So again, recommendation number 6 was discussed at our August meeting, and the qualitative elements and other factors were submitted with the additional feedback. Those elements are included in the report on page 15. I'll pause in case there are any additional edits to this recommendation. Hearing no additional changes, we can move. Oh, go ahead, Debbie.
Sorry, and I could be confused. Is this the one where we were going to do wraparound services for the family members and who suffered the fatalities, or no?
I believe that might be the next one. No, maybe. Emma, did we get that next one? I don't know if I'm seeing it on my particular list.
I think it's a harm reduction one. So
that's right.
It's coming up.
Thank you. Thanks for keeping me on track, Ms. Rodriguez. Forthcoming, Debbie. I know we have 2 different sets of recommendations that this small but mighty committee is balancing. So thank you for that. Our final prevention recommendation is, so didn't hear any additional changes to this particular one. That's now new recommendation number 6. And then prevention recommendation number 7 was around implementing changes to the recruitment, retention, and compensation of behavioral health care workers. This was resubmitted again with the discussion from August. And I'll pause here. The qualitative elements are on page 20 if you're following, for those of you following along at home. And we'll pause here for any additional changes to what's been submitted. All right, hearing none. And I do appreciate to the SEI team keeping the previous recommendations. If we can keep track of any of the numbers or where they were at in previous reports, that will be helpful, I think, for consideration for the larger surge as well. So thank you for tracking that for us. So hearing none, Ms. Nadler did submit 2 additional recommendations for consideration. These were included in the initial handout. I am noting to see if if the committee has time for including more recommendations with the 7 that we have, or if we can keep workshopping these and consider including them or discussing them or receiving presentations on them at a future meetings for consideration. Ms. Nadler, did you want to add any additional feedback to the recommendations that you submitted around the YRBS or student ID cards at this time? All right.
Whoops, I'm so sorry.
It's okay.
I unmuted myself. Not at this time. I know we've gone over. I just think those are important.
All right. Terrific. Open to input from the committee. I know we've been workshopping many of these recommendations for a few months. Open to moving forward with the 7 that we have and have received reports on and continue to workshop. My recommendation for October is we move forward with those 7 and continue to workshop these for future committee meetings or future reports, that they may not be in our 2023 report that goes to the surge,
Yep.
but continue to move them forward as part of this committee and workshop, but open to thoughts from this group. Mr. Schoen, were you going to add something? Sorry.
Sure. No, I agree with that. That reasoning that you just put forward. I feel like these are good recommendations, but they do need to be discussed in more depth.
All right, wonderful. Ms. Nadler, additional thoughts?
Yes. So to discuss these other items further in depth at a future time, the only concern I have is I know in 2024, and I'm still not sure how this is working yet, but I don't know if there's going to be new committee members, existing committee members. I'm still not quite sure what that looks like. So I hate to be, and probably all of us, in the middle of winning game in football season and the quarterback replaced, if that makes sense. I mean, we've invested our hearts and souls into this, and if we're going to put certain things out to the future, how do we remain on this committee to discuss them?
Yeah, thank you, Ms. Nadler. I believe you're referring to the term limits of the SURG subcommittee. I don't know if Dr. Kearns is available on the line to just comment if the committee members will be receiving further guidance on those at the October or December meeting. I would recommend in lieu of Dr. Kearns having a specific recommendation, that if you've identified subject matter experts who can speak on either of these, can work with Ms. Rodriguez to getting those folks scheduled at a future surge prevention subcommittee meeting to make sure that we're able to fully vet these recommendations and include them if they're not in the 2023 report, but that they're part of the ongoing work that this subcommittee is doing.
Jessica, I'm sorry, it's
go ahead,
Jerry
Dr.
Kearns, if you want
Thank
me
you.
to speak.
Yeah,
I was
thank
just
you.
going to say, under the bylaws and under the legislation, it does say the terms, but that the people can be reappointed. It doesn't necessarily go to always happen to be new members. So as we've done in the past, there's a query to see if people want to A, remain on the SURG, and B, remain on the subcommittees they're on, or if they have an interest in moving to another subcommittee. So that will all come up in a future SURG meeting.
Thank you, Terry. Thank you.
Thank you, Dr. Kearns. And thank you for your question, Debbie.
Chair Johnson, can I add something?
Please, Ms. Rodriguez.
So I know that in the last report, one or two of the subcommittees added a section that was for future consideration. So, because as you mentioned, I don't know that we'll have the opportunity to fully vet and workshop these in order to get it into the annual report. We could try, but it might end up just being, you know, maybe at the November subcommittee meeting that your members can discuss whether this should be included as a for future consideration.
Thank you, Ms. Rodriguez. I think that sounds like a nice compromise for moving forward for now. And that these are items on the SURG Prevention Subcommittee's agenda in at the beginning of 2024. All right, wonderful. I'm keeping an eye on the time, but hoping we can move quickly to agenda item number 6, unless there's additional discussion from the subcommittee here. Thank you. So the agenda item number 6 is around the harm reduction recommendations for review and discussion. I just wanted to note that the SEI team received qualitative descriptions, which are listed in the end of the handout, and will be forwarded to the full SURG for consideration at the October 11th meeting. I am keeping an eye on time, so in the interest of that, I'm going to move to agenda item number 7, unless there are, I know Ms. Rodriguez and team has looked very in-depth at these elements. Are there any particular recommendations that would be worth the committee discussing briefly?
Emma Rodriguez, for the record, I believe the one that Debbie had mentioned, and I'm trying to find it because I wasn't sure how to split it up.
Was it number 4?
Let's see here. Yes. So if you go to page 29 of the handout, let me see if I can go there on my other screen. It would just be helpful to know, I think I put it all under impact, what Debbie had sent, and I didn't want to make that determination for the whole subcommittee. So it'd just be helpful to know if that should be split up or if there's additional information that should go under all of those elements. I could share my screen if that would be helpful.
That would help me if that's all right with you, Ms. Rodriguez.
Yeah, I can do that.
And thank you to Ms. Nadler, Mr. Schoen, and others who put in the homework on the off time for the SURG subcommittee, so we could have items prepared in advance of the meeting today and for the report. I really appreciate your extra time and due diligence. Sorry to put you on the spot, Ms. Rodriguez.
No,
Thank
that's
you.
okay. So yes, so this is harm reduction recommendation number 4. Thank you so much, Debbie, for sending all of this information. I thought it probably felt it worked best under impact, but again, I didn't want to make that decision for the whole subcommittee. So I would just like guidance on if there's anything else you'd want to add or change to this part before it goes to the full SURG.
Thank you, Ms. Rodriguez. I reviewed this in advance of the meeting and agreed that these bullet points did best belong under impact. but open to other subcommittee members if you have any additional input. All right. Hearing none, it does sound like these do are best fit under impact. Thank you for pulling this up for our committee. Eric, were you reading? Sorry, we moved too fast. Okay, wonderful. All right. Thank you, Ms. Rodriguez. I'm also just going to briefly pause here in case folks have the other harm reduction recommendations up and want the committee to pause at this time to review or revisit any of the information that was provided to the SEI team in advance of this meeting. All right, hearing none, it sounds like we can move those to the October SURG meeting as is. Thank you to the SEI team for preparation of that report in advance. Agenda item number 7. So wanted to take a moment to just discuss the plan for reporting out for the October SURG meeting. So our prevention subcommittee, as you all know, has both our own prevention recommendations and then the other SURG-wide harm reduction recommendations. It's a pretty lengthy report. I was hoping to perhaps call on my vice chair, Mr. Schoen, to see if you would be open to presenting the SURG prevention recommendations. And then as chair, I'd be happy to present the harm reduction recommendations. So folks don't have to listen to me talk ad nauseum about both. But open, don't want to put you on the spot, vice chair, and open to other thoughts as well.
No, I'm happy to help out. I think many hands make lighter work, and so that seems fair to me. And if I can do that, I'm happy to do so.
Wonderful. Thank you for the volunteering / voluntold / agreeing. I appreciate that. And then thank you in advance for the preparation for the report out. Happy to represent the harm reduction recommendations as they stand for review at that committee meeting. Any other items under agenda item number 7 that would be helpful to discuss today? All right. So I'm seeing that we do have a couple of minutes left. I'm wondering if it'd be helpful to go back to prevention recommendation under agenda item number 5. Prevention recommendation number 4 to see if we want to talk through the impact, capacity, feasibility, urgency. Debbie, did I miss your hand for agenda item number 7? My apologies.
No, it's okay. I'm so sorry. I have an appointment at 1:30. Is there anything else we need to vote on? Because I don't want to miss a quorum for anything.
Ms. Rodriguez, are you able to weigh in on that?
I believe the last agenda item was just public comment after this, but we should still have a quorum even if Debbie needs to leave with who we have on now.
Terrific. Thank you for asking,
Okay.
Ms.
Okay,
Nadler.
thank y'all. Thank y'all so much. Y'all are awesome. Thank you.
Fantastic. Thank you.
Okay.
Thanks. Wonderful. So would love to hear from the subcommittee any discussion for recommendation number 4 around impact, capacity, feasibility, urgency, or advancing racial and health equity.
Hey, how much time do we have, Chair? Eric, show the record. And I know the answer to that. You already told me. So I think the potential impact of this, if this were to go forward, could be huge for helping to nudge Medicaid to a health and wellness, sort of maybe a cautious embrace of health and wellness alongside the medical model. I think that's important because it gives us additional options and tools for being proactive in getting in front of some of these really important issues. And I think we're overdue for making room for that health and wellness model to be complementary alongside the medical model, if that makes sense. And that's a more philosophical impact, but I think it'll have real tangible results when we see it implemented. Because let me just go down the road. Some of the bottlenecks that we see with treatment is that we don't have enough providers anyway. And so, you have to see a provider before they could be referred for a lower level of service to see a community health worker or what have you. And we have to find other ways to create on-ramps for people to access services that don't continue to route them to the already overburdened licensed professionals. Not that we can't have people who are certified, but we need to have an ability to be proactive as well.
Thank you, Mr. Schoen. A robust answer for this particular agenda item. Other committee members? Oh, sorry. Were you going to add to that?
I'll just say, I don't think this is an immediate impact. I think this is a slow changing, but potentially a very profound impact over the long term.
Yeah. Senator Donyate, would you like to add to that?
Sure, and I would completely agree with our vice chair. I think in general, so just for clarification purposes, the struggle that we find ourselves with expanding Medicaid billing opportunity, especially for this particular recommendation, is oftentimes there's a considerable lack of funding for starting for instance, a pilot program. The long term, I guess, and part of the agreement with Mr. Schoen, and part of his statements, right, is making sure that if there was, for instance, an example would be if there was a school district in rural Nevada that wanted to start, for instance, their own primary care clinic, right, and have the opportunity to bill through Medicaid or other avenues to run that primary care clinic, simply because maybe there's not enough in that county or in that area, that they should have the opportunity to do so. But I think that undertaking of hiring the staff to begin the onboarding of such infrastructure is probably considerate, and you would need an entire team or consulting practice to even begin that process. And so I think in coordination, I think the impact is definitely, as Mr. Schoen said, long term. But in terms of capacity and feasibility of implementation, I think part of this recommendation will also include looking at what the different CPT codes or the different billing opportunities are for such facilities to exist.
Thank you, Senator Donyate, for hopping on with that. That sounds a little bit like capacity and feasibility of implementation from my perspective, but open to putting that sort of in another category if you see differently.
So
also,
Chair Johnson, did you want me to move this part about the long term to capacity and feasibility, or what were you suggesting to be changed?
I think
go
the
ahead.
way it looks like right now is fine. I think it's correct. I mean, for the implementation of this, you will need essentially a team to start pulling, like, what are the advantages and the gaps that students are experiencing in terms of primary care or preventive services, and that probably can start. Once you identify what the gaps are and what the opportunities will be, then you can start putting dollars to creating the infrastructure, so that I would say it probably fits in capacity and feasibility of implementation. So you're correct.
Wonderful. Thank you for that. I also just wanted to add, I think for folks who provide, primary prevention services that may not be associated with a clinic or a clinical practice, in order to be able to bill Medicaid, that's very, patient-centered versus participant-centered. So some of these sort of opportunities to move more upstream into preventive services might be an additional a barrier for some agencies or entities in terms of capacity, feasibility of implementation, those types of things. I also heard Mr. Schoen say around urgency that there's a need to continue to work on this, but that it's sort of more of a slow burn. There's a profound impact over time if this if we can continue to work on this, but that that the urgency is sort of more long term.
Well, I think it goes in long, Chair, for the record, Eric Schoen, goes along with Senator Donyate's comments that there's quite a bit of infrastructure building that would have to occur for the implementation of this. I mean, if you're asking me personally, as somebody who's been doing this a long time, it's absolutely vital that we start doing this now in terms of thinking about how to deliver behavioral healthcare services and substance use disorder services that actually deliver results. Some of what we've been doing over the last few decades has not been helpful and has not worked. And so I think it's really important, but in terms of how quickly we can implement this, I do believe it'll take some time.
Thank you for that feedback as well. This has been really helpful. I'm keeping an eye on the time, wondering if any folks have thoughts on this last category around how this recommendation would advance racial or health equity. And any thoughts on that particular section? Senator Donate, go ahead.
To close this out, I mean, I think how the recommendation advances racial and health equity, addressing gaps in preventive services can help improve health outcomes. I mean, we can make it as something as basic as that. I was going to mention something about physician ratios and go deeper, but I don't think you need to. I think that's fine as is.
Terrific. Thank you so much. I wouldn't be on such a hardworking, wonderful committee if we didn't get all of the gaps filled in a single meeting. So thank you all for hopping in and workshopping this in real time in advance of our October meeting. Really appreciate it. Wonderful. With that, I'm going to move back down to agenda item number 8, which is our second period of public comment. Ms. Rodriguez, open the floor for the second round of public comment. I don't think we need to repeat anything on this slide, but I'll turn it over to you to see if we have anyone for public comment.
Chair Johnson, I see one hand raised by Jamie Ross.
Jamie Ross, you've been recognized.
Thank you so much. Can everyone hear me? Wonderful. I just wanted to, there were a couple of notes that were mentioned about mandating prevention in schools. I did want to mention that all schools, districts in the state do have required prevention training already embedded in their programs, and each school district is slightly different, but that is embedded within each school district's requirements. It does not specify opioids, as opioids are, we have historically never specified any substance, as substances change over the decades. But I did want to mention that one area that a gap exists is there is no requirement that the prevention services being given are best practices / evidence-based. That is something that the prevention agencies in Nevada, as well as the Department of Education, are working on. And a first step was institutionalized in Nevada's 2021 legislative session. And then a potential suggestion, if obviously all I can do as a member of the public is give you information. If you're interested in learning more about the Youth Risk Behavior Survey, I did see that that was in here. I could not more highly recommend Kristen Clements Knowles at UNR, who does the Youth Risk Behavior Survey, and she can explain all of the things that the YRBS already does, because I think that many of those recommendations that were suggested do already exist within Nevada. So I just wanted to plug her, as she is an incredible asset to our state, and I think would be really helpful in better understanding the YRBS and primary prevention and where our substance use numbers are in general. Thank you.
Thank you so much, Ms. Ross. Anyone else for public comment?
Chair Johnson, I do not see anybody else indicating that they wish to provide public comment.
Wonderful. Thank you, Ms. Rodriguez. With that, we'll move on to agenda item number 9, which is the adjournment. We are only 1 minute over. Thank you so much to the subcommittee members and members of the public for joining today. I really appreciate your time, energy, and effort, and a special shout out to the SEI colleagues and Ms. Rodriguez, who staffed to this committee, for always keeping us on track. All of the information from today can be found on the SURG website. Thank you all for your time. Have a great day.
Thank you, everybody. Take care, everybody.
Take care, everyone.